So today it's a little different world than, let's say, a year and a half ago, where mutational status was the only important thing for us to decide on VEGF versus EGFR inhibitors. Today, in addition to molecular characterization, and I'll quickly refer to what that means, we also have anatomic considerations. There are also, of course, other considerations: performance status, age, microsatellite status. So we're really now thinking about colon cancer, the patient that presents to us in terms of deciding on what therapy we should proceed forward with decisions that are linked to, one, molecular/genetic characterization. So it's very important to have an expanded RAS, not KRAS, an expanded RAS, which includes KRAS, expanded KRAS, expanded NRAS. And also, I think it's very important to get BRAF, because BRAF helps us a lot understand how aggressive the tumor is, and even consider 3-drug versus 2-drug therapy plus bevacizumab. Microsatellite status, very important. Everyone should get microsatellite status checked. If the patient is MSI high, then you should consider immune therapy or immune therapy clinical trial. And then anatomic location. So this now goes into the equation, regardless of the RAS status. So let's say you have a patient like this one who's RAS wild type, RAF wild type, BRAF wild type, microsatellite stable, but the tumor is on the right side. Those patients do not seem to benefit from EGFR inhibitors. So anatomic location matters, although conceptually, let's say 2 years ago, we'd think RAS wild type, you have the 2 options. Well, today, if you're on the left side of the colon, you have both options. Well, we can talk a little bit more about this. But on the right side, clearly in the first line, EGFR inhibitors do not seem to have any benefit. And so those patients, regardless of the RAS status, because of the anatomic location on the right, should receive bevacizumab plus chemotherapy if eligible first. On the left side, it gets a little bit more complicated in a good way, because then we have more options. All the studies that we have on hand, CLGB 80405, which is, of course, relevant to our practices in the US, but we also have hints from other studies, a European study like the FIRE3, which is primarily powered for response rate. CLGB was primarily powered for survival and reflects more the practices in the US. The 2 studies taken together suggest that EGFR inhibitor may have a little edge, taken together, a little edge on the left side. But when you look at the overall picture and you continue to integrate into the equation potential toxicities, you have to think about your biologics. EGFR inhibitors can cause a rash, can enhance the risk of diarrhea with chemotherapy. Bevacizumab, I say, has more silent toxicities. So when you look at the NCCN guidelines today and the way they included the right versus left story, it is clear that for the RAS wild type tumors, EGFR inhibitors in the first line are not recommended. On the other hand, for the left side, both EGFR and VEGF, so bevacizumab, cetuximab, and panitumumab, are indicated in the RAS wild type. Now, of course, if you have a RAS mutated tumor, then it's a no-brainer. It's bevacizumab as your only biologic, whether you're on the right or on the left. And that's in the first line. Now, when we start thinking about going down the line of therapy, and we'll talk a little bit more about that later, things may get a little bit different in terms of our thinking, because we start running out of options as we go down the line of therapy. But your first line of therapy is essentially the most important line of therapy, because it sets the stage for everything you do in second, third, and beyond. And it's also the line of therapy where patients spend most of their remaining lifetime on therapy. So it's very important to make the right decision in first line in terms of what biologic, based on molecular characterization, genetic characterization, as well as anatomic characterization, and add to that, of course, other clinical factors.